Welcome. I am Destiny Kelly, and I'm the National Coordinator of the NNPTC. Thank you for joining us today for the NNPTC National Human Monkeypox Virus Webinar. Today, we'll be hearing from two of our clinical faculty, Dr. Kevin Ard, Assistant Professor of Medicine, Harvard Medical School, also Director of the Sexual Health Clinic, Massachusetts General Hospital, and faculty for the Sylvia Rattel STD HIV Prevention Training Center. Additionally, we have Dr. Jason Zucker, Assistant Professor of Medicine at Columbia University Medical Center, Assistant Medical Director at the New York City STD Prevention Training Center. There will be a few minutes at the end of the webinar for a Q&A session. Please use the Q&A function on your toolbar to ask questions, not the chat function. This webinar will be recorded and you will have access to the recording within a few days, and we are not offering continuing education for this webinar. The NNPTC is made up of 8 regional prevention training centers, known as the PTCs, and 2 national centers. We are CDC funded to train clinicians in the diagnosis, treatment, and prevention of STIs. You may recognize some of the names of our 8 regional centers here on the right. And as you can see from the map, each PTC has region-specific states that they serve. I'll be sharing several products and resources we offer in the next few slides. The National STD curriculum is housed at the University of Washington PTC. The National STD curriculum is an up-to-date website for clinicians and other healthcare professionals to learn about the diagnosis and treatment and prevention of STDs and STIs. There are several self-study or quick reference lessons and interactive board review style questions, and they do offer free continuing education. The current 2nd edition integrates the 2021 CDC STI treatment guidelines. We have even more resources for you. We are excited to announce the release of the CDC's STI Treatment Guide mobile app. Please take this time to use the QR code to download the app to your phone. This version of the app is more comprehensive. Each condition has been expanded to include more information from the guidelines about clinical care as it relates to diagnosis, management, and follow-up. More integrated. In addition to having more clinical care guidance, the app provides more information and resources to integrate sexual histories into preventative care. Additionally, it has more features, clinical tools and consultation resources, which we'll talk about in the next slide, patient materials such as patient fact sheets, bookmark options, and screening recommendations. The STD Clinical Consultation Network is a free online system where clinicians can submit complex STI questions, and an NNPT expert from one of our PTCs will answer in 1 to 5 business days. The new STI Treatment Guidelines app links directly to this website to help clinicians in the management of STIs. We have recently added Mpox category to our system to assist clinicians in the diagnosis and management of Mpox. Now I'd like to turn it over to our first speaker, Dr. Kevin Ard.
Thank you, Destiny. It's a pleasure to be here today, and thank you all for joining us. Next slide, please. I'm going to be talking about the epidemiology and transmission of monkeypox, and then turn things over to my colleague, Dr. Zucker, to discuss the clinical presentation and treatment before I then return to talk about vaccination. This slide is from November 4th, 2022, and at that time, there were 78,000 cases as part of this global outbreak. As you can see, most of these are in countries which did not historically report monkeypox outside of a few travel-related cases. And the US is the most affected country by number of cases currently. Next slide, please. There is geographic variation within the US. The states which have had the most cases per susceptible or population at increased risk for monkeypox are shown in dark blue. And within these states and others, this is largely an urban infection, although of course there are infections also seen in rural areas. Next slide, please. Unfortunately, there are disparities by race ethnicity in cases of monkeypox, and as we'll talk about when we get to the vaccine segment, these are really the converse of disparities we see in vaccine administration. So although overall cases are down, still a majority of infections are occurring among Black and Hispanic Latinx individuals. Next slide, please. Although people of any sexual orientation or gender identity can be affected, cisgender men who have sex with men are most affected so far. And you can see that the more than 90% of cases are among men. And in case series of monkeypox in this outbreak, more than 90% of affected men identify sex with other men as a potential risk factor for infection. Next slide, please. We'll talk about the clinical presentation more in a few moments, but already in some ways, this outbreak differs substantially from prior reports of monkeypox. And before May 2020, when the first case was reported in the US, if you had picked up a textbook or read an article with a description of monkeypox, the illness that you read about would have been different in some substantial ways from what we're seeing now. One is the predominance of infections among young men who have sex with men, and the spread of infection through this sexual and social network. You'll hear more about the incubation, the prodrome or lack of prodrome, and other clinical features seen in this outbreak in a few moments. Next slide, please. As you are likely aware, cases are down overall. This shows the epidemic curve for the US as a whole, with a substantial decline in cases from a peak in early August. Next slide, please. And the effective reproductive number in this outbreak, which is the number of people who are anticipated to become infected from one person with the infection, has dropped below 1 as of late July 2022. That is just another indication that the outbreak is contracting in size, as we saw from the case numbers overall. Next slide, please. So why do we see this decline in cases? Well, unfortunately, one reason may be immunity through natural infection among the population at greatest risk for the infection. Another is immunity through vaccination, although the timing of the decline suggests that vaccination alone is not the only cause or perhaps even the main cause for this decline in cases. There's also been well-documented behavior change, and that's shown in this figure here from a CDC report, in which a survey of gay, bisexual, and other MSM performed in August found that nearly half had reduced the number of sex partners, half had reduced one-time sexual encounters, and half had also reduced sex with people that they met on dating apps or at sex venues in response to this outbreak. Next slide, please. What about transmission? The primary mode of transmission in this outbreak is thought to be close physical contact, including sexual contact. And there have been several questions over time about what sources of infection may be, which body fluids, for example, may be capable of transmitting the infection, and thus what types of exposures may transmit the infection. This is a very useful table from a CDC scientific report showing the exposure sources from which monkeypox virus DNA has been detected, those from which replication-competent virus has been detected or isolated, and then those which are epidemiologically supported as a source of infection. And you can see that when you look at the epidemiologically supported sources of infection, these are now skin, the oropharynx and saliva, the anorectum, and then also contaminated sharps. And although virus may be found in many of the other sources you see there, we don't yet know for sure if those are important sources of infection for other or transmission for other individuals. Next slide, please. Another common question has been if pre-symptomatic or asymptomatic transmission is possible. We do know that monkeypox virus has been identified in rectal swabs of people without symptoms, swabs that were performed for another reason, such as screening for gonorrhea and chlamydia. And analyses of case pairs have reached different conclusions about pre-symptomatic transmission. For example, in a CDC analysis, it appeared that there was pre-rash transmission, but not necessarily pre-symptomatic transmission. But in a different analysis, there was an indication that pre-symptomatic transmission may occur. I do think it's useful to think about if we say did confirm that pre-symptomatic or asymptomatic transmission was happening, if or how this would change our public and clinical health approaches. I think we would still recommend many of the same strategies that we're recommending now, including vaccination. Although, for example, if it were known that pre-symptomatic or asymptomatic transmission was happening, then that might increase demand for vaccination. So this is an area of active investigation. Next slide, please. I will now turn things over to my colleague, Dr. Zucker, to talk about the clinical presentation of monkeypox.
Thank you very much, Dr. Ard. I really appreciate the thorough introduction to get us started here. So now that we've covered a little bit about how it spreads, let's take a second to talk about how human monkeypox virus presents. So on the left-hand side and on this slide, we're talking about the classic presentation, or as Dr. Ard described it, what you would expect to see if you read a book on human monkeypox virus. The disease starts with a viral prodrome, similar to many viral illnesses. This includes things like fevers, chills, headache, malaise, myalgias, and lymphadenopathy. After the prodrome, the patient usually develops a rash. The rash usually occurs before day 5 and most commonly on days 1 to 3. These rashes are firm, deep-seated, well circumscribed, and are sometimes umbilicated, and we'll see a lot of pictures of rashes coming up. They classically start on the face and spread to the extremities, including the palms and soles, and they classically progress through several synchronized stages. They can be very painful and last up to 4 weeks. Next slide, please. So this is my classic human monkeypox virus presentation slide. The virus starts with an incubation period of 5 to 21 days. That means that after a significant exposure, it can be up to 21 days before you have any symptoms, although it more commonly occurs around days 6 to 7. Next slide, please. That's followed by the prodrome we described earlier, with fever, feeling tired, headache, sore throat, cough, and swollen lymph nodes again. Next slide, please. Followed by an anathome, which is where lesions start in the mouth. During this period, you can have infectious virus in your mouth that can spread through kissing and oral contact before you may realize that you are infected. Next slide, please. That's followed by macules, which are flat lesions on the skin. And because they're small and flat, they can be easy to miss. Next slide. Those are followed by papules, which are solid and superficial, not yet fluid-filled. They're generally small and can be easily confused for acne. Next slide, please. These can then progress to vesicles, which remain small and filled with clear fluid. Next slide, please. And can then progress to pustules, which are filled with a darker fluid, more consistent with pus. They can also become umbilicated in this stage, developing a hole in the center, like seen on those bottom 2 pictures, which is extremely classic for this disease. Next slide, please. After that, they start to scab. And it's important to note that the scabs are still very infectious. Next slide, please. Patients are not considered fully resolved and no longer infectious until the scabs have fallen off and there's new fresh skin underneath. Next slide, please. Because of that, the infectious period is long. The infectious period lasts from when the prodromal symptoms start until the scabs fall off. Patients can be infectious for as long as 21 days or longer, which makes this disease very challenging to manage. Next slide, please. So to understand how human monkeypox virus is presenting differently during this outbreak, we can look at a few of the many case series that have been published. And I did my best to put some of these findings into a table to help us see some of the trends. Next slide, please. One of the first things that's obvious is that the majority of cases in this outbreak are male, greater than 95% in most case series, compared to about 1/3 in the African case series. This is likely related to how the disease is transmitted across networks more than anything about the virus itself. Another important thing to note is that a disproportionate percentage of patients, around 40% across studies, are persons living with HIV. Slide, please. Second is that while we're going to hear a lot about other symptoms, the rash is still common and prevalent in most patients. However, what you don't see from just this table is that in many cases, the rash appears after other symptoms instead of being the initial symptom. Next slide, please. One of these major symptoms is rectal pain, presenting as proctitis with and without tenesmus. This occurs in between 14 and 36% of these case series, and is one of the major unique symptoms of this outbreak. Next slide, please. And this symptom also fits with lesion location. The majority of patients have lesions on their genitals or perianal regions. These are frequently the locations the rash begins, which really differentiates it from the classic presentation. What's also interesting is we're not seeing a huge number of lesions like had been reported in prior African case series. In many of these case series, the median number of lesions is around or less than 10. Next slide, please. So to briefly summarize the way human monkeypox virus is presenting during this outbreak, it's occurring primarily among gay, bisexual, and other men who have sex with men. There are a smaller number of cases transmitting to women and adolescents via close contact during sexual activity, and younger children via household spread. The prodrome may or may not be present, or may occur after other symptoms. The rash remains incredibly common, but is presenting atypically. It often starts in the genital or perianal areas, and mucous membrane involvement is common. Scattered or diffuse lesions, or lesions localized to a single body site, can both occur, and lesions in different stages of progression side by side have been reported as well. Next slide, please. I also want to highlight some of the more severe and significant presentations because human monkeypox virus can be a severe disease. I want to start by thanking our patients for providing us permission to share their stories and images to help us providers better take care of patients, and provide a warning that some of the images in the next few slides will be graphic. Next slide, please. The first manifestation I want to highlight is less severe, but no less important, and it's this viral-like exanthem. We're seeing this in numerous patients, and it was not really reported prior to this outbreak, but tends to improve as the patients improve. It's important to think about this because it can look like many other viral and other infectious exanthem. Next slide, please. We're also seeing significant genital lesions. As I said before, having lesions to the genital and perianal areas are not uncommon. Here you can see penile lesions having that classic umbilicated appearance, rectal lesions having what looks like a pseudopustular appearance, and vaginal lesions as well that look very similar to the rectal lesions. Again, genital lesions are a prominent presentation during this outbreak. Next slide, please. So I also want to cover some significant presentations that we're seeing. Things like proctitis, urethritis, pharyngitis, perichondritis, ocular disease, lymphadenopathy, bacterial superinfection, persistent and progressive disease, and encephalitis. Next slide, please. The first thing I want to highlight is proctitis. And as we said, this is an extremely common symptom presenting during this outbreak. Some things to know about proctitis is patients can actually have extremely severe proctitis and pain, even if they don't have external lesions. In this particular case, this patient presented with proctitis with severe pain. He then later developed lesions on his skin that tested positive for human monkeypox virus. He actually never had external lesions in the perianal or rectal area. However, on sigmoidoscopy, they found significant ulcerations consistent with monkeypox virus disease. Next slide, please. Next is urethritis. And hopefully you can see on the screen, but there are actually 2 lesions in this patient's meatus, urethral meatus. This patient presented with severe dysuria that we initially thought was consistent with other sexually transmitted infections. He did not have any skin lesions at the initial time of presentation, but again, developed them later. So dysuria or urethritis can be a presenting symptom of human monkeypox virus. Next slide, please. Pharyngitis has been a very common symptom for us, and actually been one of the major reasons we've had to admit patients to the hospital due to inability to take oral intake. So patients can present with pharyngitis and also develop the lesions later as well. Next slide, please. Perichondritis is an unusual symptom. We've only seen 1 case of it, but this was through direct inoculation of both ears. And this patient had severely progressive perichondritis that actually needed IV antiviral therapy that we'll talk about in a little bit to treat prior to improvement. So again, you can see very unusual presentations. This patient actually presented initially with these ear lesions. So I go back one more. With these ear lesions, then developed the viral prodrome, then developed skin lesions later. So this was actually the presenting symptom again. Next slide, please. Ocular disease has been well reported at this point by the CDC. This report describes just 5 cases, but there have been many others. One of the things that they want to highlight is that patients with ocular disease experience delays in treatment, initiation, prolonged illness, hospitalization, and vision impairment. Because ocular monkeypox is a sight-threatening condition, and patients who may have ocular monkeypox need to be considered for urgent ophthalmic evaluation and treatment. Patient can get this both as their initial presentation, but more commonly as a secondary infection through autoinoculation. Next slide, please. We've also seen significant amounts of lymphadenopathy. This is just one patient who presented describing feeling like he was wearing a fanny pack along his waist due to the significant lymphadenopathy that can be extremely painful It can also make it easy to confuse it with things like syphilis and bacterial infection that can also cause lymphadenopathy. So it's important to remember that lymphadenopathy fits very well with this particular presentation. Next slide, please. Bacterial superinfection has been extremely common, particularly among rectal and genital lesions. Here are 4 patients, all who had pretty significant genital infections that were all treated with an antiviral medication, tecovirimat, that we'll talk about shortly, antibiotics and good wound care. And as you can see, next slide, please. They all did heal relatively well. So it's important to know that good outpatient management can allow you to care for these patients without admission, but certainly requires consultation with our genitourinary colleagues to ensure good outcomes. And in all 4 of these cases, all patients have mild scarring, but no ongoing dysfunction or functional limitation. Next slide, please. So this is one of the more significant presentations. This is a patient with persistent progressive disease. The CDC recently released an MMWR highlighting about 57 cases of patients with persistent or progressive disease, most of whom had AIDS with extremely low CD4 counts. In patients with extremely low CD4 counts, they're unable to clear the virus, and the virus can persist on, causing ongoing disease for long periods of time. In this case, this patient was actually positive for over 4 months in spite of multiple courses of antiviral therapy. And so it's important to remember that patients with HIV, particularly those with low CD4 counts, really need to be offered antiviral therapy as early as possible. Next slide, please. And the same thing is true. The same thing is true for this patient, same patient as well, who also had genital lesions that became severely progressive. Several cases of encephalitis reported across the United States and around the world, which has been one of the causes for mortality in this disease. And so while rare, it's another presentation you should be aware of. Next slide, please. Yeah, we mentioned before about these cases of significant progressive disease, and most of them have occurred in patients living with HIV with extremely low CD4 counts. Next slide, please. Just some lessons learned about these significant presentations. You know, the significant presentations may be the presenting symptom and can occur pre-rash and pre-prodrome. A high index of suspicion is needed, especially if you have a reasonable pre-test probability. And most patients can be managed in the outpatient setting in consultation with subspecialists. Next slide, please. Back one slide, please. Yep. So remember, there's a wide differential diagnosis for human monkeypox virus. The diffuse rash can look like a lot of different things, including syphilis, varicella, herpes simplex virus, molluscum, other pox viruses, disseminated fungal infections, disseminated gonorrhea, and enterovirus, particularly hand, foot, and mouth disease, which is quite prevalent at this point in time. The genital ulcer disease can look like herpes simplex virus, syphilis, chancroid, and LGV. And proctitis can be confused with gonorrhea, chlamydia, herpes simplex virus, and syphilis. I highlighted syphilis in red because it's probably the #1 diagnosis that I confuse for human monkeypox virus, because they can look extremely similar in a variety of cases. Next slide, please. But they also can occur simultaneously, so it's important that we do comprehensive STI testing. In this report from the CDC, 38% of patients were living with HIV, and 41% of patients had an STI in the past year. In our patients that we've seen with human monkeypox virus, approximately 1/3 have been co-infected with another sexually transmitted infection, highlighting this endemics that are going on and highlighting the fact that we can't rule out an STI just because we rule in human monkeypox virus, and we can't rule out human monkeypox virus just because we rule in a sexually transmitted infection. Next slide, please. So to briefly summarize the way the virus is presenting during this outbreak, it's occurring primarily among gay, bisexual, and other men who have sex with men, with a small number of infections spreading to women and children, primarily via household spread. The typical rash also remains common, but it's presenting atypically, often involving mucous membranes starting in the genital or perianal areas. Lesions can be scattered or diffuse and can be on a specific body site with less total lesions, usually less than 10, compared to other cohorts. Differential diagnosis and co-infection with STIs is common, and so don't forget about complete STI testing. Next slide, please. How do we treat human monkeypox virus? Next slide, please. The first and most important thing is that most patients fully recover with or without treatment. However, as also mentioned here, there is considerable morbidity, and supportive care can help patients when they're recovering. Next slide, please. Most of the symptomatic treatment recommendations are not strictly evidence-based, but they make sense. And the CDC did a great job collating the experience from a variety of providers early in the outbreak to put together a Dear Colleague letter. Next slide, please. Supportive care recommendations include for proctitis, things like stool softeners to decrease pain when going to the bathroom, and especially for patients who end up on opioids. Topical agents like sitz baths and lidocaine gels, but to be careful with local immunosuppressives that have the potential to worsen disease. Pain control also includes over-the-counter pain relievers like NSAIDs if patients are not bleeding, or Tylenol. And finally, prescription analgesics like gabapentin or opioids if needed. I always recommend care and consideration with opioids due to the risk of constipation, making things worse. But there are patients whose pain we are not able to control in any other way. For pharyngeal disease, we have topical agents as well, like viscous lidocaine and saltwater gargles, as well as over-the-counter prescription pain relief. Finally, while not in the Dear Colleague letter, we found one of our largest complications to be bacterial superinfection of genital lesions, as I showed you earlier. And so we recommend patients trying to keep that area clean as best they can and consider topical or other systemic antibiotics as well when needed, as well as wet to dry dressings for patients who may need some mild debridement. Next slide, please. As a reminder, not everyone needs antiviral treatment. However, some patients do. Patients who need antiviral treatment include patients or who may need additional treatment, not just antiviral treatment, but also vaccine immunoglobulin, include patients with severe disease, patients with illness complications, and those at high risk for severe disease, like those with HIV with a low CD4 count, and those who are immunosuppressed. Next slide. Okay. For vaccine immunoglobulin, this is best for patients who have severe disease, and as well as patients who are severely immunosuppressed. It's a vaccine immunoglobulin that's been shown to be effective in treatment of vaccinia. Although we don't have a lot of data on human monkeypox virus, it has been used significantly for patients with severe disease and severe immunocompromise. It's also been used as well for prophylaxis and post-exposure prophylaxis in individuals who are also severely immunocompromised. Next slide, please. In terms of antivirals, there are 3 systemic and 1 topical that I'll review. Remember that orthopox viruses are not herpes viruses, and acyclovir, which requires phosphorylation, is not going to be active. However, both cidofovir and brincidofovir are potential agents against orthopox viruses. Cidofovir acts as a competitive inhibitor and an alternate substrate for DNA polymerase. It gets incorporated into the growing DNA strand, blocking DNA synthesis, leading to non-productive infections. However, given the low overall mortality of this disease and the significant risk of renal injury with cidofovir, this drug has primarily been saved for patients with severe and progressive disease. Brincidofovir is a similar drug, but it has a side chain that gets cleaved, releasing cidofovir that's thought to have less renal toxicity. Next slide, please. Brincidofovir was initially used in England. In fact, the first 3 patients were treated with oral brincidofovir about 7 days after onset during a previous outbreak. Disappointingly, all 3 patients developed elevated alanine transaminase, and none were able to complete the course of treatment, dampening some enthusiasm for this drug. With that said, there recently is an FDA IND that does allow access to this drug from the Strategic National Stockpile for patients who may need it as a second agent, as patients who may not be responding to other antiviral agents or may be severely immunocompromised and progressing. Next slide, please. Next, and I'll mention this only briefly, but trifluoridine drops. These eye drops are FDA approved for herpes infection of the eye and are thought to have activity against orthopox viruses. They've been recommended by the CDC in most cases of severe ocular disease. Next slide, please. Finally, tecovirimat. Tecovirimat is an antiviral drug initially developed against variola to treat smallpox infection. And it works by inhibiting a viral protein P37 that's highly conserved across orthopox viruses, allowing tecovirimat to have in vitro activity against most orthopox viruses. It's also highly selective. Tecovirimat was approved in 2018 via the FDA Animal Efficacy Rule, or Animal Rule, which allows a pathway for approval of drugs for severe or life-threatening conditions when it's not ethical or feasible to conduct efficacy trials in humans. So it was approved only for smallpox. Next slide, please. And because it was approved for smallpox with the Animal Rule, prior to this outbreak, we had extremely limited human data on this medication. efficacy data was done entirely through non-human primate studies. And this is the human safety study that led to its approval. Prior to this outbreak, there were about 359 patients in the safety study with only one serious adverse event that was not attributed to the drug. Next slide. In terms of efficacy prior to this outbreak, there's really, again, this same paper, the 7-patient case series in which 3 got entadalpavir. 1 patient was treated with tecovirimat, experienced no adverse effects, and had a shorter duration of viral shedding and illness. Now, hopefully we all recognize that 1 patient is more anecdote than data. Next slide, please. Well, we're starting to see more and more case reports about individuals' experience with tecovirimat. This was a case report of 2 patients whose proctitis improved on tecovirimat, as well as a case series of 26 cases as well. Next slide, please. And then the CDC has a case series with 549 patients, although only 174 with intake and outcome. What we can really see from some of these observational retrospective case series is that there's good safety data for this drug now. You know, we've given out almost over 5,000 courses in the United States, and there have been extremely low levels of adverse events. The vast majority of them being, as you see on this slide, things like headache, nausea, visual disturbance, weakness. So the drug does appear to be extremely safe. Next slide, please. But that doesn't negate the fact that we still need to figure out whether or not this drug works for human monkeypox virus. We still need a clinical trial that can help us know definitively if the drugs work and is safe. It can let us know if learn if the virus develops resistance to the drug. Understand what markers tell us that the drug is working so we can identify future promising drugs. But if it doesn't work, we're spending time and money that could be used to find drugs that do. And so it is really important that we conduct a clinical trial. And the good news is that one is ongoing currently. Next slide, please. The NIH, along with the ACTG, rapidly developed a treatment trial called the Study of Tecovirimat for Human Monkeypox Virus, or STOMP. It's a 2-to-1 randomized, blinded, placebo-controlled trial with an open label arm for certain participants. Next slide, please. So just to sum up what I tell my patients with human monkeypox virus, I like to tell my patients who test positive that we have supportive care options for all patients, as well as a clinical trial for patients who are interested. We have an EA-IND for tecovirimat for patients with severe disease. Patients should stay home and separate from other people in their household. If they can't fully separate, which is very common, especially in New York City, wear a face mask, avoid physical contact, and cover lesions when in shared spaces. If you must leave your home, cover your rash and lesions with clothing and wear a face mask. One other question that every one of my patients so far has asked me is, when can I have sex again after human monkeypox virus? And the truth is that currently there's very little data. Consider condoms for a minimum of 8 weeks after infection. And the WHO actually says consider condoms for a minimum of 12 weeks after recovery. But the hope is that we'll have more data on this in the future. And with that, I'll turn it back over to Dr. Ard.
Thank you, Dr. Zucker. And this is just a slide about the STOMP trial. All right, we'll now finish up by talking about vaccination. Next slide, please. The vaccine being used during this current outbreak is the MVA-BN vaccine, or Jynneos. This is a replication-deficient vaccinia virus, which is licensed as a 2-dose vaccine with those 2 subcutaneous doses given 4 weeks apart. And separate from this outbreak, it was recommended by the ACIP, the Advisory Committee on Immunization Practices, as pre-exposure prophylaxis for laboratory and other personnel who had occupational exposure to orthopox viruses, including monkeypox. The only contraindication is severe allergy to a vaccine component. The vaccine does include ciprofloxacin, gentamicin, and egg. And side effects are typically injection site reactions, which tend to be mild. Serious side effects are thought to be rare. Next slide, please. Now, there is an older vaccine that is available called ACAM2000. This is a live replication competent vaccine. And I'm showing here a table from the ACIP statement on MVA-BN. And I think you can see from this table why we are not favoring ACAM2000 for use to respond to this outbreak. ACAM2000 exhibits what's called take. That means that there is viral replication at the site of inoculation that could potentially spread or be transmitted to other people. And so ACAM2000 is contraindicated in those who are immunocompromised or who have household contacts who are immunocompromised. You can see the other contraindications there. And then in contrast, Jynneos, or MVA-BN, has just one contraindication, and that being serious vaccine component allergy. Next slide, please. Now, MVA-BN was approved by the FDA based on having immune responses that were non-inferior to those of ACAM2000. And I'm showing those data here. This is from a study published in the New England Journal of Medicine. You can see that at 2 weeks, antibody titers are similar between Jynneos and ACAM2000. And then at 6 weeks, they're the same or higher in the Jynneos group. And at 6 weeks or 2 weeks after the second dose of Jynneos, people are considered fully immunized. Next slide, please. So what are the current strategies being used for vaccination in response to this outbreak? Well, one strategy is post-exposure vaccination, or PEP vaccination. And this was the first strategy that was used. PEP is for people with a confirmed exposure to human monkeypox virus, and that could be through a public health investigation, through contact tracing, and so forth. But also there is a strategy called PEP++, and this is vaccination for people with presumed exposure to monkeypox. So for example, people who know that a sex partner in the last 14 days was diagnosed, people who've had more than one sex partner in the last 14 days, or people who've had sex at a commercial sex venue or at an event where monkeypox transmission was occurring. Next slide, please. Now, subsequently, we began pre-exposure vaccination strategies. And these are for people who are anticipated to have exposure to monkeypox in the future. The CDC has guidelines on this, and then each state is able to improvise a bit on those. And so I'm showing here the eligibility criteria in Massachusetts. So people who are gay, bisexual, or other men who have sex with men, or transgender or non-binary people who in the last 6 months have had a new STI or more than one sex partner, people who've had sex at a commercial sex venue, such as at a bathhouse, and then people who've had sex at a large public event like a rave. In addition, this would include people whose sex partners have had those risks, even if they themselves have not had those risks, or people who anticipate experiencing any of the things that I listed above. And so those individuals are eligible for pre-exposure vaccination. And importantly, as part of a crucial stigma mitigation strategy, people don't have to be asked a long list of questions about each of these activities, but can simply attest to being eligible for the vaccine. And I should correct an error. These are the CDC criteria. The parentheses about Massachusetts there is a typo. Next slide, please. Now, many of you are likely aware that the strategy shifted away from subcutaneous dosing for most people to intradermal dosing in early August, when that approach received FDA emergency use authorization. Next slide, please. The rationale for intradermal dosing is really to stretch the vaccine supply. We do know that antibody responses to intradermal dosing are non-inferior to those of subcutaneous dosing based off of a study published in 2015. And recall that this vaccine was approved by the FDA based on its immune responses. The intradermal administration requires 1/5 of the subcutaneous dose. That's not a low dose, but thought to be the correct dose for the intradermal location, because that area of the body has a large number of immune cells and can be easily stimulated by a small amount of vaccine. The intradermal approach is now the preferred approach for those who are 18 years of age or older with no history of keloids, keloids being considered a contraindication to intradermal dosing. Next slide, please. Now, the intradermal site of administration can have some redness and swelling or hypopigmentation that can last for weeks and be slow to resolve. And so some patients may not want to receive it on the forearm, which is the standard location. And so there are alternative sites where people can receive the vaccine, including the upper back below the scapula, and then also the deltoid. Next slide, please. So in a short period of time, our monkeypox vaccine strategies have shifted a great deal. And I'm showing here the evolution that has occurred where I work in Massachusetts and also in many other places in the country. We began with a 2-dose subcutaneous vaccine series administered as PEP or PEP++. We and then several other jurisdictions switched to what was called a first dose prioritization strategy. That was not recommended by CDC or FDA, but was undertaken by some jurisdictions because of local concerns about vaccine supply. And then in that approach, people received a dose of vaccine with a plan to give the second dose when it became available, but not necessarily at 28 days. With the emergency use authorization for intradermal administration, we switched back to a scheduled 2-dose 28-day schedule. And then a bit over a month ago, expanded to pre-exposure vaccination, again, using the 2-dose intradermal schedule for most individuals. Next slide, please. Early data suggests that the vaccine is effective. And so in this analysis from CDC, human monkeypox infection was 14 times more likely among people who were unvaccinated than people who had received at least 1 dose of the vaccine. Next slide, please. There are, however, important disparities by race, ethnicity in the vaccine effort. More than 980,000 doses of vaccine have been given as of October 2022. But these disparities really persist. And you can see that although a majority of cases are among Black and Hispanic Latinx people, that over 50% in many weeks of vaccines have been administered in white individuals. Next slide, please. And so the CDC has identified multiple strategies to try to improve vaccine equity, and I'm showing several examples here. These include engaging people from all affected communities in vaccine planning and delivery, providing information in a range of languages and through multiple channels, making vaccines available at community events and organizations, and offering vaccines outside of regular business hours, including evenings and weekends, and also walk-in vaccination. And then providing vaccines at clinics that are already serving people with historically limited access to care, including federally qualified health centers. Next slide, please. And so now I'll turn things over to my colleague, Barbara Wilgus, who will lead the Q&A session.
Hello, everyone. And Dr. Zucker, if you can put your screen back up, or slide screen, whatever, back up. I would love for folks to enter any questions you may have into the Q&A function at your bottom toolbar. We also have with us from the CDC, Elizabeth Olson and James Lee, in case you have any questions that might need a CDC kind of answer. And while we wait for people to type, maybe I'll just throw a little kind of softball out here, hopefully a medium ball. So as numbers, as we are kind of in this side of a bell curve, it appears, but also knowing that in other parts of the country, it may not be that same way. Also, things can change, as we have learned much over the past 2 years. As patients are now coming in with questions, how are you counseling the patients that you see about monkeypox prevention, what they need to do now? And my second part to that would be, how would you also counsel other providers who are asking, what they need to do to remain vigilant and be ready in case one comes?
So I can begin to make an answer. I'm still certainly recommending vaccine for everyone who's eligible. And I think, in many ways, vaccine efforts have evolved. And so although now, people seeking the vaccine can certainly receive it in many places, we're also identifying people who've come for another service, maybe for STI screening, for a PrEP visit, and we identify that they're eligible, or they express that they're eligible, and we offer the vaccine then. And so I think that's crucial. And then I kind of, you asked about other providers. We also kind of relay that message to other providers. If you know that one of your patients is potentially eligible, please talk to them about the vaccine and then link them to the vaccine.
I guess I can add on to that. I think, absolutely, vaccination is number one. It's our best public health effort for virtually everything when we have one. So starting with vaccines, I think, is absolutely critical. And then providing counseling to my patients, the same things I sort of tell them about other sexually transmitted infections. Talk with and check out your partners, have open conversations with your partners about symptoms or exposures, and then examine yourself regularly. If you find anything suspicious, give me a call. We can bring you in and make sure you get tested as soon as possible. Other sort of the same guidance we provide them for anything really applies here as well.
And can speakers share any experience regarding cases among adolescents or questions that at-risk youth may have?
I can take that one, I guess. So we've had a couple of adolescents so far. Most of the adolescents transmission has been similar to our adult transmission, which means sexually related transmission. There obviously are some younger children who've had household exposures and likely some probably older ones as well. But for the most part, the adolescents we've seen have been sexual transmission. And so we're telling them the exact same things that we're telling our adult patients. Get vaccinated if you're eligible. You know, that's certainly a challenge for adolescents throughout the United States because in every state, I think, except New York, it's not considered an STI. So New York State a month or so ago gave a temporary exemption, making an STI through January of 2023, which allows adolescents to consent for testing, treatment, and vaccination without parental consent. In most jurisdictions, that's not available. And so you certainly need to be able to involve the parents in this so that patients can get tested, get treated, and get vaccinated to protect themselves.
That is something I completely did not think about until now. So that's why my face lit up because, wow, that's good, important information to consider. Wow. Couple of vaccine questions. Is it anticipated for there to be any additional vaccine supply available?
So I can start with that. So currently the vaccine is distributed from the strategic national stockpile through state and local jurisdictions. And currently, I believe there is a possibility to order more through that channel. So I would encourage anybody who is running low to discuss with their jurisdictional supplier to make sure that we get your needs met.
And is it expected that intradermal will continue to be the recommended method of administration, or will the recommended method of administration return to subcutaneous?
So I see someone else chose to answer that live as well, so I'll defer. But currently, intradermal is still preferred. However, some jurisdictions have chosen to make more subcutaneous vaccine available. I would note that there are certainly circumstances under which patients would be given subcutaneous over intradermal, particularly if they have keloids, if they haven't tolerated the first dose well. In the interim clinical considerations, patients refusing to get a dose intradermally is also a reason to consider subcutaneous use. And I know that different jurisdictions have approached this a little bit differently. We are continuing to reevaluate how to best meet everyone's needs.
I don't know if Kevin, Dr. Ard has any additional thoughts on that, but I'll also add that adolescence is another indication for subcutaneous. The EUA for intradermal is only for greater than 18. So for our adolescents age under 18, it's going to be subcutaneous dosing only.
There is also a clinical trial of different vaccine strategies. And so it's possible that based on the results of that study, when those are available, that our strategy may be refined even more.
Any other questions for our speakers? And as we wait, I will maybe just ask if you had one kind of single pearl of wisdom, which I realize is going to be a gigantic pearl like this, based upon your early lessons learned. What how would you, what would be your single most important lesson that you think you've learned during this outbreak?
I guess I'll take this
Ongoing.
one.
No, I'm
I
just
guess I'll
looking
take
at the Q&A, seeing if anybody's asking anything.
I can take this one first. I think the number one thing I've learned is have a really high index of suspicion. I presented a lot of different presentations that people presented with. And what I found is that many of those patients reported no rash, although on a detailed and careful skin exam, you can often find a couple lesions that look like acne, that look like other things that when you swab end up turning up positive. And so, as always, it goes back to detailed history and physical exams, which us and ID really love to do. But taking a good history, having a high index of suspicion when patients present with unusual symptoms, and then doing a careful skin exam and swabbing unusual lesions.
I think maybe similar to what Dr. Zucker said, I think one lesson I take away from this is really about clinical reasoning. And I actually think back to the first US case that was identified by a colleague of mine, actually. It's now been reported in the New England Journal, but they were faced with this first case and not really knowing that an outbreak was happening. And so it was really, the person was initially thought to have HSV. And of course that was treated and tested for, and then those results came back negative. And so then they had to kind of think, I wonder what this is now. And also, went through a list of other possible things that were investigated. And so I think it's just important to kind of, trust your eyes and your ears, and there will be the next thing, whatever that is. And there will be a first clinician who identifies it. And so it's really just, I guess, a reminder to, when things don't seem to make sense or add up, to kind of seek help and ask questions.
And just to also remind providers that that's what we're here for too, to answer those questions. I'm sorry, I interrupted you, James.
Hey, and then I want to advertise that, we here at CDC, we have a clinical consult service that we can that we're happy to discuss unusual or severe presentations of monkeypox with. You can call us at 1-800-CDC-INFO, or you can reach us at EOC event 482@cdc.gov. And then and then this will be a place to facilitate therapeutics such as IV ticagrelor, vaccine IVIG, as well as just to hear what we'd love to hear what you're seeing in the field also.
Here's another question. Any recommendations for how to address the disparities in people's access to vaccine?
I think it gets back in many ways to some of the strategies that I mentioned. And I think, part of the kind of core of many of those is really making vaccine as available as possible through as many different avenues as possible, so that people can access it, wherever they are, however they're seeking care. Also making sure that they're aware of it. And so, spreading the word about vaccine through multiple different types of channels and media. And I don't know if our CDC colleagues want to share anything else about CDC approach on that.
Certainly, I think I would also highlight, in addition to the tremendous work that state and local jurisdictions are already doing to try to make vaccine more widely available and partnering with others in their community. There's also an equity grant initiative. So there are there are opportunities involved available for small grants to facilitate initiatives that are aimed at precisely this, at making sure that we get vaccine to populations where it's most needed and where people have had diminished access to the vaccine so far. I'll put a little bit more information about this in the chat, and then please also feel free to start conversations with your local jurisdictions about the equity access programs.
I'll also just add to that, putting vaccines everywhere is huge, and putting them in the hands of people that, underserved populations trust, I think, is a huge thing, and among our populations, in New York City, everyone saw the photos of people waiting outside the sexual health center for vaccinations at the beginning of the epidemic, and that did not lead to an equitable distribution. But then New York City really switched, and the first thing they did was actually give us appointments at those centers for our patients, because we serve an underserved population, and that helped a lot. But then we still had patients who were resistant to even going down there. So the next thing they did was give us vaccinations so that we could give it to our patients in our own clinic, partnering with community-based organizations that we've worked with for a long time that refer their patients in. And I think working with these community groups, making vaccine available to groups that have been serving these populations for long periods of time is really how you increase the equitability of these vaccine rollouts.
This is all wonderful information too, and valuable resources. So thank you for putting those into the chat as well. Any further questions? I'm seeing lots of thank yous. So if there are not any further questions, Destiny, did you want to wrap us up?
Yes, thank you so much for our presenters, our CDC colleagues, for everyone that is on the front lines of the
Did she freeze for anybody else? Okay.
I'm going to echo what likely she is saying at her home behind her frozen computer, which is thank you to everyone who has been there working hard on this frontline response. It has really been one of the, in my short career of 20 years, 25, 6, 7 years, something like that, it has been one of the most really boots on the ground, what is happening, let's figure this out all together kind of communal efforts on a national front that I've seen, well, since COVID, since the last, but hopefully with, a shorter and final outcome, or so close to final outcome. So I want to thank our speakers and thank everyone from coming from the CDC. Thank you all for being here, and have a wonderful day, and take forth everything you have learned and impart it to everyone around you. And we're happy to be here if you have further questions or consults needed, or any other resources you might require during this time. Thanks, everyone. Have a great day.
Thank you.
Thank you.